I would like to thank everyone for attending tonight. I know you all have evenings and families to attend to, but recognize that you're here because you're seeking more information on something that is of high clinical relevance to your practices and to the patients that you're looking to keep safe. Before we get started and I turn it over to Dr. Gin, I would just like to begin with a land acknowledgement. Manitoba pharmacists provide care to all people on the original lands of the Anishinaabe, Cree, Ojibwe, Dakota, and Dene peoples, and on the homeland of the Métis Nation. We honor the treaties that were made on these territories and acknowledge the harms and mistakes of the past. We also appreciate the important role that traditional medicines have had for Indigenous peoples in health and healing, and hope to work with all people with respect for their traditions and cultural backgrounds. I also recognize that some folks on this call may not be calling in from Treaty 1 lands, which is where Winnipeg is situated. I encourage you to say hello in the chat and share where you're calling from, which lands, city, and or pharmacy. Also, please note that throughout today's session, you may ask questions using the chat function or the Q&A function, which is likely located on the bottom of your screen. Alternatively, if you prefer to voice your question, you may do so using the raise hand feature, at which point the host will allow you to speak by unmuting your mic. That said, I ask that, in terms of verbal questions, we'll give Dr. Gin a chance to go through the presentation. Chances are he'll answer your questions proactively, but we will have time for Q&A at the end. And also, I am the technical host of this Zoom call, so I apologize for any technical shortcomings. They are my fault and my fault entirely if they happen. With that in mind, I am going to introduce Dr. Alfred Gin. Alfred obtained his BScPharm undergraduate degree from the University of Manitoba and his PharmD at the University of Buffalo. He is an infectious diseases clinical pharmacist at the Health Sciences Centre, Winnipeg, with over 30 years of infectious disease experience working closely with the section of infectious diseases. Alfred has a cross appointment as an assistant professor with the Department of Medical Microbiology and Infectious Diseases at the Max Rady College of Medicine, University of Manitoba. He has numerous presentations, research projects, and publications listed in his CV. Alfred has a keen interest in optimizing antimicrobial use and approaching questions from a broader clinical perspective. He is active on many professional committees, working groups, and organizations, especially with the Canadian Society of Hospital Pharmacists. He enjoys problem-solving challenges and is a tech geek at heart. So with that in mind, let's welcome Dr. Alfred Gin, and please take it away, Alfred.
All right, thank you for the kind words. I'd like to thank Tim and Pharmacists Manitoba for inviting me to speak on Paxlovid, which is of keen interest of mine. For the last 4 months, I've been one of many pharmacists in Manitoba that were designated Paxlovid screeners, so I have a little bit of experience with that. So we have, in terms of screening patients for drug interactions as it relates to Paxlovid. So with that, I'm just going to I also have a similar acknowledgement, which for the sake of time, then Tim and Pharmacists Manitoba covered that. So I'm just going to move on. I have no conflicts to declare, and by choice, I have no affiliation with the pharmaceutical industry. So as we know, in terms of COVID, we really have limited treatment in terms of targeting SARS-CoV-2, which is a virus responsible for treating COVID or causing COVID. The monoclonal antibodies were used for quite a bit in the early months, but because of mutations and the Omicron variants, the use of the monoclonal antibodies have declined markedly because of lack of effectiveness. And that just leaves us two antivirals. One is remdesivir, which can only be given intravenously. And the other one, of course, is Paxlovid, which was rolled out in late January. And Paxlovid, as you can see here, is the trade name, but it's made of two drugs, nirmatrelvir and ritonavir, and can only be given orally. Initially, the Paxlovid started to, in all the provinces, centralized distribution models, but then as the demand increased, they were moved from a centralized distribution towards community pharmacies as the points where patients can access Paxlovid. And in all provinces in Canada, Paxlovid is now distributed through that particular model. And in 4 of the provinces, I believe Saskatchewan, right beside us, Quebec, New Brunswick, and I believe Newfoundland, Labrador also have pharmacists who are able to prescribe Paxlovid in the community. So I'm not going to go over all this, but I'm going to cover all these different points as it relates to Paxlovid. And we have a long presentation, so I just want to cover all these different areas. And we can do that. And I have a few case examples as it relates to screening for Paxlovid. And these are some of the same slides that I've also presented to Doctors Manitoba just last week. So Shared Health has an active website, and this is the information source you go to. They have the most current information that is always being updated, and you'll find if you need to pull out a document or any updates and guidelines, it's best to always check with the Shared Health site, because they do change. And for example, when we were screening Paxlovid, possible Paxlovid patients, we find some physicians were using old forms which were like 2 to 3 months outdated. So if you need to pull information down, go to this current site and you'll get the most up-to-date information for all physicians, pharmacists, nurse practitioners. So this is the previous model, and the previous model was that a physician or a patient would contact health links, and the referral forms would be filled out, and it'd be directed towards central intake, where there's a nurse and a pharmacist like myself who would ultimately review the referral forms to see if a patient is eligible for Paxlovid. And once that was done, we would send our recommendations to the prescriber at Access Winnipeg, one of the Access sites, who would then review our recommendation, then fax the prescription to a pharmacy, which would then distribute, sent to the patient. During that time, as the pharmacist, we were doing drug interaction screening. We were doing a lot of patient interviews. If we had to, we would contact the primary physician, and we would write up our recommendations. Because we were working within a clinic environment, we were using electronic medical record, and which required a lot of documentation. If patients weren't ineligible for Paxlovid, they would then be redirected for remdesivir infusion, which can only occur at limited sites in Manitoba, and with the limited spaces and very specific criteria, only a certain number of patients could actually get intravenous remdesivir. In the new model that was implemented just a couple of weeks ago in Winnipeg and now across Manitoba, the patient can contact the physician, who would then determine whether the patient qualifies for Paxlovid. Prescription would be sent to a participating community pharmacy, who would then do the drug interaction screening and et cetera. And then, of course, will fill the prescription for the patient. But these two blue lines represent communication between the physician and the pharmacy. Remdesivir intravenous infusion is available, but because we're now opening up to a broader number of patients who could get Paxlovid, the number of remdesivir slots for patients to go get remdesivir is still the same number. So that hasn't changed. So there's limited space, and they have very specific qualifying criteria. So Paxlovid in Canada, when it was first approved, was approved just in mid-January for adults who had positive test results and were at a high risk of progression to COVID-19, requiring possibly resulting in hospitalization or death. Paxlovid is not authorized for patients who are really sick, let's say in the ICU, or for those who were, for pre-exposure prophylaxis or post-exposure prophylaxis, or for use longer than 5 days. And I'll show you some information as it relates to the pre-exposure and post-exposure. So Shared Health came up with some updated guidelines in mid-May, and this applies to all patients and for all prescribers to refer to, is that Paxlovid can be prescribed to a patient who has symptoms within 5 days of its onset. The patient has to have mild to moderate symptoms with no imminent hospitalization. In other words, they can't be sick enough to require hospitalization and say oxygen. And of course, they have to be test positive. So patients have to be 18 years or older, but kids 12 years or older are also allowed within this set of guidelines, providing their minimum 40 kilograms. So for some of you may see the occasional pediatric prescription. In terms of the groups that Paxlovid is targeted towards, it's the patients who are immunocompromised, who are unable to mount any antibody response, even with vaccination. So these are patients that this is a long list, and you can go to the Shared Health website for the specifics. Maybe say patients who are receiving active chemotherapy, renal transplant patients who are receiving a monoclonal antibody like infliximab or adalimumab. There are also patients who are what would be termed as immunocompetent, but because they have of a certain age, ethnicity, they were never vaccinated or partially vaccinated, or they have chronic health conditions like diabetes, obesity, etc., or if they're pregnant, they would also qualify for Paxlovid treatment. So that's for the med chemists. This is nirmatrelvir. And nirmatrelvir is the active compound, the active antiviral that targets SARS-CoV-2. And it is known as a main protease inhibitor specific to SARS-CoV-2. And I'll review that in the next slide. Nirmatrelvir is renal-eliminated, but in patients who have an EGFR less than 30, the half-life doubles. So that impacts the way, limits the number of patients or the types of patients that can get Paxlovid. It is metabolized by the cytochrome P450 CYP3A, and it is active against SARS-CoV-2, all variants, including the latest Omicron variant. So it is still active against that, in stark contrast to the monoclonal antibodies. The ritonavir is also specifically there as a protease inhibitor, but we're using it as to boost nirmatrelvir, and ritonavir is commonly used in HIV therapy to boost an antiretroviral. So in this case, just give me an idea, with the addition of ritonavir, it increases the exposure to nirmatrelvir by 27 times. So otherwise, it would just be totally eliminated from the body really quickly without ritonavir. This is the sort of schematic of what happens with SARS-CoV-2 gets into a cell and infects the cell. So the first thing it does, once it gets in, it opens up and unloads its viral RNA. And one of the first things it does is it does a protein translation to create these two sets of proteins, PP1 and PP1AB. And it cleaves off this main protease, this MPRO, and that enzyme is responsible for chopping up these proteins into all these little bits, which then form the virus coat for the SARS-CoV-2. Well, what nirmatrelvir does is it blocks this MPRO from chopping up these bigger proteins. So it works inside the cell, and it's very specific to SARS-CoV-2, and essentially will shut down virus production in infected cells. It doesn't do anything for those that are circulating, but in terms of the being an antiviral, it works and shuts down infected cells from making more viruses. So it all comes in terms of the clinical study. There was a study that compared in high-risk patients who had a high risk of severe outcomes or greater than 60 years of age, FB positive. And the study compared nirmatrelvir and ritonavir, that is Paxlovid versus placebo. They had to have symptoms less than 5 days. And the primary endpoint was hospitalization or death by any cause by day 28. So that was the main clinical study. And what they found in their analysis that when you look at the Paxlovid arm, 8 patients out of 1,000, which is 0.8%, compared to 66 patients out of 1,000, 6.3%, were either hospitalized or had deaths. And you look at the number of deaths at the very bottom here for the placebo side, it's far greater than that of the Paxlovid side. And that results in a relative risk reduction of almost 90% in terms of decreasing the risk of hospitalization in patients who receive Paxlovid. This is the adverse reactions as it relates to Paxlovid, and by far the most common is taste disturbance, and it's sort of a metallic taste. And you look at the incidence, it's like 6% compared to placebo, which is 0.3%. In the late media, they describe it as Paxlovid mouth, and there's one description that one person was quoted as saying, if they imagine what grapefruit juice tastes like with soap added, that is Paxlovid. So some would describe it as a metallic taste. It's pretty common. 1 out of every 10 patients, 1 out of every 5 patients may develop this taste disturbance. The second most common side effect, and it's far less than that of taste disturbance, would be diarrhea. And it's far less than that of the taste disturbance, but it is 3 times or double that of the placebo side. So patients may develop diarrhea or may not even notice it. The reason I say that is because COVID can also cause diarrhea. So one of the questions that arises that physicians have been asked is, or could be asked, is that, the patient may go to them and say, I've tested positive, I have symptoms, but I don't really have any risk factors. Can I get a prescription for Paxlovid to decrease my symptoms? So what Pfizer had a study, they looked at Paxlovid in the treating patients who were called standard risk, in other words, UNI, low risk of hospitalization, and they were looking to see if there's any reduction in symptoms. And they found that in their interim analysis, there is no difference in symptom reduction compared to patients who received placebo. So Paxlovid doesn't work for that purpose in basically relatively healthy patients without risk factors. Another question that comes up is that I've had exposure to a family member who just tested positive and has symptoms. Can I take Paxlovid prophylactically? Well, Pfizer just released their results just a little bit over a month ago. They did their study and they looked at 5 and 10 days of Paxlovid as prophylaxis in patients who were asymptomatic and test negative, but were exposed to someone in the household who was positive. And again, similar to the last study, they found there is no, Paxlovid did not reduce the risk of COVID occurring in patients who receive post-exposure prophylaxis. So if you were asked, someone asks you, it doesn't work for that particular purpose. It seems to work only in patients who have high risk, severe symptoms or severe outcomes with respect to COVID. So in terms of dosing, it's a single 5-day course and it's 10 doses. And we've been asked to make sure that, and this is what I told physicians last week, was that the prescription is not to be refilled or repeated, and there's no extension. There is talk of rebound COVID that's in the media, but that's as I understand, they're going to be investigating that in terms of a clinical study to see whether there is anything as it relates to rebound and the duration of Paxlovid. In terms of the dose, it's all based on renal function, specifically eGFR. So the eGFR, in this case, it's greater than 60. They get a standard dose of 2 tablets plus 1 tablet of ritonavir, or a total of 30 tablets. If they have a eGFR of 30 to 59, they get 1 tablet of nirmatrelvir and 1 tablet of ritonavir, again, every 12 hours for 5 days, and that's 20 tablets. So the physician should be screening and determining what the patient's eGFR is and when they write the prescription for Paxlovid. For those who haven't dispensed Paxlovid yet, this is what it looks like. It's a box that contains 5 blister cards. Each blister card is divided as a gold color morning side and a blue color evening side. There's 2 tablets of nirmatrelvir and 1 tablet of ritonavir, as you could see. And it occurs, you see that in all 5 blister cards. The tablets are a little bit on the large side. On average, they're about almost 1.8 centimeters in length and almost 0.9 centimeters in width. But the requirement is that patients must be able to swallow the tablet whole. They cannot crush it, they cannot split it, they cannot dissolve it, they can't take it with or without food. And in our screening, we learned really early we had to add that into our screening questions because we encountered, during the first week, patients who, when they received it, discovered they could not swallow Paxlovid. So we had to make other treatment options for them. A missed dose can be given within 8 hours. Otherwise, they can skip it, take the next dose, but they can move that missed dose to the very end, so they can still complete 10 doses of Paxlovid. And this is one of the key things as relates to the renal dose adjustment, and it's done by pharmacy. And what it is that the 2 tablets of nirmatrelvir will be popped out, 1 on each side of the morning and evening dose. So this is what we did when we initially did this, was that I put this label over the empty cells, just to indicate that the patient's blister cards have been modified for their dose that's prescribed by the physician. But in reality, you could cover it, and you could choose to cover it with or without text. You can leave it uncovered, but the main thing is just to let your patients know what they will be receiving, so that they know that they're going to be getting a Paxlovid that's been adjusted for their renal function with nirmatrelvir removed. And that's really important because that patients who have that 30 to 59 eGFR range, they need to have their blister cards modified. Is Paxlovid contraindicated in pregnancy? It is not. There is no data as it relates to Paxlovid in pregnant women because of clinical trials. They always exclude pregnant women. But we do know from ritonavir, there's a lot of safety and clinical experience with pregnant women with HIV. The expectation of nirmatrelvir will be quite similar. And the reality is that when a physician has a discussion, and you may have the same discussion in your pharmacy, is that that the benefits and clinical need may outweigh the perceived risk as it relates to Paxlovid and COVID disease. So that's something that needs to be actively discussed if their patient is hesitant in terms of, say, deciding they do not want their prescription or at their counter or at when they receive it at home. As it relates to breastfeeding, there again, no data, but there's a lot of clinical experience that relates to ritonavir, again, with the pregnant women with HIV. And in discussion between the physician and patient, for example, or yourself and the patient, the benefits of breastfeeding far outweigh the concerns that may be from not treating a mother who has COVID infection. And LACME, which is a lactation database, came out and indicated that it's expected that in the nursing infant that yes, there will be a small amount of nirmatrelvir that gets into the milk, but the amount is considered to be small and it's unlikely to affect the infant. And the reality is nirmatrelvir will not be absorbed, or at least be very poorly absorbed in the nursing infant's gut. So that will decrease, again, the exposure to nirmatrelvir. So there are contraindications for nirmatrelvir, and these are at eGFRs less than 30, really bad liver function, which is child's Pugh class C, hypersensitivity Paxlovid, inability to swallow large pills, and drug interactions, and specifically unmanageable drug interactions, which is why the bulk of my presentation. And this is sort of that elephant in the room that physicians are very concerned about because they're not sure how they would screen, and they're unfamiliar with screening and interpreting the literature or the recommendations with Paxlovid, specifically as a result of ritonavir. So ritonavir is a very, very potent inhibitor of cytochrome P is CYP3A. The onset of inhibition starts about and reaches maximum effect about 2 to 3 days after initiation of ritonavir, and the offset will occur about 3 to 5 days following the discontinuation of the ritonavir. And a lot of this is new information as it relates, as relates to Paxlovid, because Paxlovid is 5 days, but there's no data into the drug interactions with 5-day treatment as it relates to ritonavir. So a lot of this is based on extrapolation, a lot of estimation, and as a result of trying to expand the number of patients who are eligible, there's a lot of recommendations as it relates to drug interactions. Specifically in terms of drug interactions, some of the drug interactions could be like an absolute contraindication to something very mild where the patient can take it and we would not be concerned with the type of drug interaction because it's a mild or it's just only a weak drug interaction. But we do know that if the patients are not screened, a severe drug interaction can lead to significant patient harm. So, I'm sure that in every province, there's been at least one case where someone has not had appropriate Paxlovid screening and significant harm may have occurred. So these are some examples of Paxlovid interaction. So if a patient is getting atorvastatin, for example, and Paxlovid, you get increased concentrations of atorvastatin. Tacrolimus, you get really increased concentrations of tacrolimus, so much so that we were extremely concerned about the interaction even before Paxlovid was rolled out. If a patient's on rifampin or St. John's wort, you get decreased amounts of Paxlovid significantly, where there's no Paxlovid in the system, essentially, because both rifampin and St. John's wort rev up the liver enzyme, which essentially burn up Paxlovid. It's the latter three that would be considered make patients ineligible to receive Paxlovid and be classified as an unmanageable drug interaction. So Charity Health came out with this document in May 18th, the time when they indicated there would be a transition from the previous centralized model to a distribution model through community pharmacies. And in there, they highlight that pharmacists are well placed to be, based on our expertise and our knowledge, will be reviewing Paxlovid prescriptions, are strongly encouraged to flag medication interactions, but also make treatment recommendations to prescribers where a drug interaction with Paxlovid is identified. Just 2 days ago, on Monday, Shared Health came out because they're so concerned about the physicians not appreciating how much drug interaction screening should be done with Paxlovid. They came out with this document, again, emphasizing all the resources that are available to physicians. They do mention pharmacists as well within the document. And they also had in their second and third page 6 sample scenarios. Again, this is sent out Monday to all physicians in the province, again, reminding them that drug interaction screening for Paxlovid is crucial. So in their scenario examples, they included comments about DOACs, calcium channel blocking immunosuppressants like tacrolimus, antiplatelet agents, statins. I put down immunosuppressants twice and I didn't catch that. My apologies. And zopiclone. But what they did is only for sample. They chose one resource for each particular drug scenario. But there are lots of different options that exist, which is what we are able to review because we have the ability to screen a lot of different resources to come up with options that may fit the patient best. So in terms of drug interactions and eligibility, this is what it looks like. So it's easy for patients to be on the green side. There's no interactions. The red side would be the unmanageable drug interactions. But what we're trying to do in our screening is get more patients into this eligible Paxlovid range here, where you can, we may be able to modify their medications through either holding, decreasing dose, suggesting another alternative to try to get more patients to be eligible for Paxlovid. And there's a smaller number here where they may be eligible to modification, but it's just not practical. And I'll cover that in a couple slides later. So Shared Health at their website also includes a document, a list of different drugs. It's not as elegant as some of the other resources I'll cover, but it's a list of drugs where they classified drug interactions as do not administer with Paxlovid or do not administer Paxlovid, hold one or more drugs as applicable, modifying the dose of the drug, or using a substitute drug. So those are the 4 different options. And in our screening, we did options 1 to 3 more commonly, just because we've always were able to redirect a patient to get remdesivir because we work so closely with the screening process. But in the new process that, again, I mentioned that remdesivir slots or openings for patients to get remdesivir hasn't changed. So we probably have to work a little bit harder to try to ensure that a patient can get Paxlovid safely. So I did indicate there has to be something practical, and some patients, it may not be possible with a number of dose changes, or they're really elderly, they cannot manage all these medication changes. The patient's getting blister packs, for example, they get 6 different medications in blister packs because they just pop out. It's very hard to adjust medications because of those blister packs. And I know when I was screening a 92-year-old, and she was on several drugs, but in order for her to get Paxlovid, she would have to have 4 different drug changes, 2 drug holds, 1 dose reduction, and 1 monitor to see as just a monitor for adverse effects. And just the way when I talked to her, I didn't feel comfortable getting her to make all these changes because I wasn't sure she was able to do 4 different drugs while she was taking Paxlovid. So we redirected her to alternative treatment. So in terms of the flow of how, in the new process, the patient will contact the physician with symptoms, and they may indicate to the physician they have a rapid test positive. The physician will then send the prescription to a participating community pharmacy, and that's where us pharmacists will do drug interaction screening. So I know that when we're doing drug interaction screening, there's different components, and we've done it all. It's not something new, but for what I did, for example, I would review the DPIN for medications so I could get a good feeling for what they're on, and then we would contact them, do medication review, verbally with the patient, and correlate it with the DPIN. And we learned so many new things because we found out patients who stopped the drug or restarted a drug that's not reflected in the DPIN. Sometimes there's dose increases or dose changes that would occur, again, not reflected in the DPIN. We would ask them about their non-prescription medications, any recreational products, again, just to make sure know what they're on and to screen them for interactions with Paxlovid. We would always ask them if they're taking any herbal products, and a good example of St. John's wort, because they couldn't get Paxlovid because St. John's wort would essentially burn up Paxlovid through metabolism. We identify drug interactions and management options, and we would then forward those recommendations to the prescriber, including if we have identified patients who were not able to get Paxlovid because they're of an unmanageable drug interaction. These are the drug interaction resources. So again, I've already mentioned about Shared Health, but the most common one that we use was Liverpool, which is they have an online checker, which was great. They also have a phone app, and they have a PDF documents. Ontario Science Table, again, has a really comprehensive document as well that's accessible. And the BC CDC has documents as well as videos for their pharmacists. So when they made their transition from moving from a centralized model to community pharmacy distribution, they also had videos for those for pharmacists. But all these have something in particular, is that they assess their drug interactions based on the expected duration of Paxlovid and provide recommendations in terms of how to manage those drug interactions. This is what the screen, for example, on the Liverpool online checker would look like. The nematrivir here is checked off when I filled it in. In this case, you can see I put in alfuzosin as the drug, and you can see here that it gives an output of do not co-administer. And I can't do this now because this is a screenshot, but you would scroll down their detailed information at the bottom just to see why is this a red, and are there other management options for getting a patient to be eligible for Paxlovid. All these particular resources have PDF documents, and you use color codes or a combination of color codes and symbols or letters. So Liverpool has this, and you can see they break it down based on, so green is good. Anything that's green is good to go. And then they have increases in terms of the types of severity by change of color, as well as the wording in terms of do not use Paxlovid, for example, use other alternatives. Again, it's a gradation of severity of the interaction. Ontario Science Table has something similar, but they move from something like 8 different, instead of having 8 different levels, they have 5 levels here. One is the contraindicated if it's recent use. And again, green check mark is good. And then when you start getting into the orange diamond and the red stop sign or octagon, we'd have to closely look at what changes, if any, we would make to a patient's medications. BC CDC uses a even less of a or different type of legend. Green is good for okay, but then they have this M for modifiable. Red is not a good thing, but basically what it means is you have to make a modification if a patient is to be able to get Paxlovid. So in this case, they're saying for alfuzosin, the interaction increases the amount of alfuzosin, which can cause a patient to be hypotensive. And if appropriate, you can hold the drug, the specific alfuzosin, and you can restart it 3 days after finishing Paxlovid. So that's a modifiable drug interaction. And what all of us did was we would use all 3 resources just to screen to make sure that they're in the same kind of vein in terms of recommendations. So the most common drugs that we encountered in our screening were, we had patients who always seem to be on statins, whether it be like, atorvastatin or rosuvastatin. And the most common recommendations we would make for those patients were, that we would hold the statin for 8 days. And this is our recommendation to the physician. That's 8 days in total, 5 days where they're in Paxlovid, and for another 3 days afterwards. And the patient can restart a statin on day 9. Next most common was DOACs, that is the direct oral anticoagulants like apixaban or rivaroxaban. There's a lot of different options that are available, and I'll talk about that in the next following slides. Amlodipine, we had a lot of patients who were always on amlodipine, so the recommendations were to decrease the dose by 50%. And in one case, I remember the patient was on such a low dose. I think she was like taking 2.5 milligrams, like breaking in half a 5 milligram tablet. Her dose was so low that it was easy to ask her to hold the drug, with her physician's approval, and her daughter could monitor her blood pressure. But again, she was on such a low dose, we could not break a half a tablet into, say, a quarter of a tablet, and because it wasn't a reasonable thing to do. Zopicol was the next most common, and we would ask patients to reduce or hold their Zopicol, just because it can increase the amount of Zopicol and it does increase the sedative effects. And then after that is tacrolimus, which I'll talk about later on as well. So this is a good example that's drawn from our experience. So this is a 57-year-old patient with Crohn's. We did a dependent patient med history. He was on infliximab for his Crohn's, and he was also getting alfuzosin 10 milligrams daily and atorvastatin 20 milligrams daily, and a bunch of vitamins, which were, upon screening, what you get used to, where there was no direct drug interaction whatsoever with those ones. So this is what we would do. We look at alfuzosin, we would compare across the board to see what they would say. So yes, they have the different ways of presenting the drug interaction. There is a pharmacokinetic rationale as it relates to the drug interaction and what their management options were. But as you can see, generally they say the same thing. That is hold the alfuzosin for 7 to 8 days, and you can restart on day 9. And then even though there's a little bit of difference, they're essentially saying the same thing. When we look at atorvastatin, for example, we also will see the same type of presentation in terms of the interactions. It's a little bit different in the way they present it. you look at atorvastatin, they also will say the same thing. So, basically hold the drug, or you can decrease the dose of atorvastatin. Most commonly, what we do is we just ask the patient to hold the drugs. You could hold atorvastatin specifically, for example, just because statin use is a long-term benefit, a long-term outcome. So short-term holding of the drug will have no effect on the particular patient. So that's a atorvastatin, and we saw that quite common. We often ask patients to hold. So the recommendation we would make to the prescriber, as well as in our counseling to the patient, was hold efusisin for 8 days, while on Paxlovid is 5 days Paxlovid, and for another 3 days after. The same thing would go for atorvastatin, and this would be our recommendation. And the patient would be able to complete Paxlovid and restart the medications without any harm whatsoever. If we take the same screening case and we add amiodarone, so what if the patient were receiving amiodarone? Well, if we look at amiodarone, for example, then it gets a little bit trickier. So there's a little bit more warnings involved. So, the Liverpool says do not co-administer. Ontario Science Table says contraindicated. BC-CDC has this M for modifiable, but again, a red symbol. And the thing about amiodarone is it's in the body for a long time. It's got a really long elimination half-life. And even if the patient were to stop amiodarone when they start Paxlovid, because it's in there for such a long time, there's going to be a drug interaction that can be very significant. So both Liverpool and Ontario Science Table essentially say stop don't give Paxlovid, use an alternative agent. BC-CDC says, well, yeah, there is that you get increased half-life and it's a narrow therapeutic index, but maybe you can consult a physician. We would probably do this, and we would probably approach a physician only if we had no choice. That is to say, a cardiologist to comment on the patient's amiodarone if we could not get, say, a patient intravenous remdesivir treatment. We have to go back to Paxlovid. So this would be the recommendation that would be given to that particular prescriber. Patients are not eligible for Paxlovid due to an unmanageable drug interaction between Paxlovid and the long half-life of amiodarone. Consider alternative treatment. And again, once the prescriber receives that, they would then fill out a referral form for remdesivir intravenous treatment. And the way it's infused or the availability really varies depending on the health region that you are in. So when we see a patient in our referral form, and in this case, it's a 49-year-old renal transplant, I did the DPEN and as well as the med history as well. But as soon as I see the word tacrolimus in there, it didn't matter what other drugs they were taking, just the word tacrolimus and the significant drug interaction may occur, we identified them immediately as Paxlovid ineligible. So if you looking at the resources, what do they say about tacrolimus? So they do all say the same thing: do not co-administer. They all have red symbols. There's a lot of pharmacokinetic information. But if you look, and this is I extrapolate from the long text, but essentially what they're saying: consider alternative treatment. But if you had to, you would do very close monitoring tacrolimus and do dose adjustments. And they also essentially say the same thing. BC-CDC says TDM is difficult, and they say it's possible. But in reality, we cannot get tacrolimus levels, instantly. And patients who have renal transplants or solid organ transplant like a lung, they're all over the province, and access to tacrolimus levels may not be available. And just by routine, we would not attempt to do therapeutic drug monitoring of tacrolimus in a patient who receives Paxlovid. We essentially say they're ineligible. We will get the remdesivir into these patients by infusion. Shared Health, because the same concerns, and they came out with this last week, was they're concerned, and they sent this notice to all physicians, all pharmacists across the province, was that well, not all pharmacists, but it's posted on their website that that if you had patients who were like transplant patients in Manitoba, well, Paxlovid can increase the concentrations of tacrolimus significantly, also sirolimus, as well as cyclosporin. And they don't actually say it's contraindicated, but they use the term avoid Paxlovid, consider remdesivir. And if need be, the transplant program for that patient, whether it's a kidney transplant or lung transplant program, those prescribers may need to be contacted to for them to get involved. And if a prescriber wants Paxlovid and these patients are on it, so the transplant program would not mind being contacted to get involved to ensure a patient does not get Paxlovid. Again, because it's so dangerous in terms of that interaction. Again, these DOACs, that's one thing I was referring to. We saw a lot of patients who are getting a DOAC, whether it's a Pixaban or a rivaroxaban. So this is a case that, this case, the patient had a history of an MI and stent insertion. He also had a history of asthma. You can see he was getting a Pixaban, metformin, and all these inhalers. He's taking the multivitamin, but it was the Pixaban that was flagged as a drug interaction. So Apixaban or any of these DOACs can be a little bit of a problem because it all depends on what is the indication, what is their dose. So when we look at the Liverpool, Ontario Science Table, and the BC CDC, they do not co-administer, and then your options really depend on what is the indication, say atrial fib versus venous thrombosis, VTE prevention. And there are different alternatives, whether to hold the Apixaban in this case, reduce the dose, or use an alternative agent. If it's for venous thrombus, embolus kind of prevention, then consider using low molecular weight aspirin or low dose aspirin. This is the same thing as applies to Ontario Science Table. BC CDC is a little bit different. They suggest going with considering switching to Delbicatran. But I just want to emphasize that is very specific as it relates to British Columbia. The Ontario Science Table came up with a very good graphic indicating, all the different questions and options for a patient who may be getting a DOAC. And again, it depends on what is the type of the DOAC. Is it for AFib versus VTE prevention? Does the patient have an artificial valve? What is the dose? And the options would be continue to hold, dose change, alternative agents, etc. They do have up here refer patient for remdesivir upfront, but because of limited slots, we would try to get patients eligible to receive Paxlovid through some type of modification in their medications, if possible, and if practical. This is what it looks like a little bit more detail, and they have lots of different options that prescribers and pharmacists can work together in choosing the best option for the patient. Some of these options may not be practical depending on how well you know the patient, age, abilities, etc. So there are options to get a patient to receive Paxlovid, whether it be a different DOAC or a different anticoagulant. BC CDC is different in that they suggest switching to Delbicatran for 10 days. It's premised on the fact that the patient can follow instructions, will fill the Delbicatran prescription, and will get a follow-up call from the pharmacist. This again, emphasize it's specific to BC. Delbicatran dose has to be adjusted by eGFR. So in the BC therapeutic document, they have this little section here which gives all the different details that relates to the use of Delbicatran to replace a Pixaban or rivaroxaban. It may not be suitable for use for your patients. Again, it really depends on what your patient is getting, why they're getting a DOAC. So, in going back to this particular case, we would have a conversation with the prescriber and patient, just find out what they're getting, and if it's a low risk, prophylaxis in terms of venous thrombosis and prophylaxis, they could probably get low dose aspirin for 7 to 8 days. That is by holding their Pixaban while they're getting Paxlovid, or they're high risk, maybe consider switching to a low molecular weight heparin, dalteparin subcut, for example, again for that same 7 to 8 day duration. And one of the I can tell you from experience talking to patients who are getting, say, Pixaban as an example, we often encounter patients who would tell us, "Oh yeah, the cardiologist started me, didn't think I needed it, but thought, well, I might as well just start it anyway." So that gave us the opportunity to contact the cardiologist to ask them, "Can we hold the drug, while they're getting Paxlovid?" And surprisingly, for the right patient, they would say yes, the patient can have their DOAC held. So they're even holding a DOAC is definitely an option, depending on what they tell you. I remember one patient specifically, their DPIN says they're getting a Pixaban, only found out that she stopped on her own. And I asked her, did you let your physician know? And she said, yeah, she knows well, but I just restarted 2 weeks ago, but I have no problems stopping it, is what she had said. And I figured, she probably could stop it because the long-term physician knows and she's well aware, she's eligible for Paxlovid. So we had that conversation, and she reaffirmed that she would hold apixaban. So there are some key points that relate to drug interactions. Specifically, resources can be in agreement, but differences do occur. The resources are not exhaustive. And if a drug is not in any of these resources, it does not mean that there is no drug interactions. Sometimes it's overlooked. There may be, it's a new drug, or say a monograph, for example, might refer to another CYP3A inhibitor, but not ritonavir by name. And as pharmacists, we would probably need to investigate. This is how the drug interaction flow would occur, as we would provide information. The physician is also expected to do a little bit of drug interaction screening if possible to decrease the amount of workload on pharmacists. Specifically, if they know their patient, for example, is on apixaban, they could probably write on the prescription patient to hold apixaban or to yada, yada, yada. And lastly, this is my last case. Not last case, but I remember this case. This is my very first case. So what you're looking at is just, I believe, I can't remember the actual 12 medications. She was actually my very first screening. This particular patient was on 20 drugs. So I'm only giving you a screenshot of only some of the drugs. So that was my first screening I had to do for Paxlovid on a patient who had 20 different medications. But she knew her medications like there was no tomorrow. She was very confident about medications. She had long-standing rheumatoid arthritis, getting a lot of opioid painkillers and anti-inflammatory agents. And what we focused on, what identified right away, was the potential interaction with her opiates as well as trazodone. So when you look at its screening, they can increase oxycodone concentrations and to consider a dose reduction. That's per the Liverpool database. So we suggested to her just decrease her oxyneal to 40 milligrams while she's getting Paxlovid. Trazodone, again, potential for increased concentrations. We suggest that she decrease her trazodone from 200 milligrams to 100 milligrams at bedtime for the same duration. But in terms of her pain control, it was emphasized that because she was able to titrate, the goal was to maintain pain control and not to have her be in any pain. And she was able to do that through modifications, but more frequent Percocet. And if she felt, more pain, she could adjust her oxyneal back to TID. So these were presented to the prescriber for consideration. So in final, tips for pharmacists: medication history is crucial. Consult at least 2 drug interaction resources. And once you start doing it, it actually goes very quickly. It took us time because we had to do a lot of documentation into electronic records. It gives us an opportunity in terms of when we're screening to identify and interpret findings for the prescriber as well as for the patient. And when you're reviewing these resources, it's important to read the full information so you have a better understanding of what the options in terms of management are telling you and how you decide which is best for your patient. And there's also a great opportunity for us to collaborate with the prescriber. So in summary, Paxlovid in Manitoba is now available across the province for immunocompromised patients and patients who are at risk of severe disease. By far, the most challenging aspect of Paxlovid is the drug interaction, so much so that's why the Sheriff Health has sent a couple memos because of the concern with drug interactions or possible lack of screening by physicians. And it's really important, as we know, to do careful, detailed drug interaction screening because it can have a significant impact in making a patient eligible or ineligible for Paxlovid. And we are by far in the best position to do this based on our training. And there's a great opportunity for us to have that communication open between the physician and us as pharmacists. So with that, thank you for attending my presentation, and I'll be open at this point for any questions that you may have regarding Paxlovid or drug interaction screening.
Awesome. So first off, thank you, Alfred, for a fantastic presentation, very comprehensive. And there are a couple questions in the chat, but I'm going to use my moderator's privilege to ask mine first. You noted early in the presentation that studies showed no benefit for use in prophylaxis in standard risk patients. Has there been any evidence showing efficacy one way or another for prophylaxis in high risk patients?
There has never been study in prophylaxis for high-risk patients.
Okay.
So again, I can think one of the challenges with, and so there's that too. So one is use for symptom relief, and then the other one was the trial for post-exposure prophylaxis. If I recall, they did try to enroll high-risk patients into that. One of the problems with that is post-exposure prophylaxis is probably an inefficient way of using Paxlovid because the patient doesn't have the virus, and they can get exposed or get infected long after Paxlovid is gone. So that's the difficulty with doing post-exposure prophylaxis.
Okay, that makes sense. Got a couple here from the chat. So first one is, do probiotics help prevent or manage the side effect of diarrhea? Or I guess how concerned about the diarrhea are we?
That's a great question. Personally, I was never concerned about patients having the diarrhea, just because even though the number looked like it was high, it was not that common, and the patients by far were probably more concerned with that taste disturbance. I'm not aware though of probiotic actually being used to prevent diarrhea as it relates. That's something that has been associated with like C. diff. I'm not sure that it may work due to drug-related cause.
Okay. Next, can a patient who has received Paxlovid in the past be prescribed Paxlovid again should they be reinfected in the future?
Yes. So if they were, say, so I'll give you the scenario and I'll just change it up and then I'll answer directly. So if the patient, for example, still had symptoms within that same week, they should not be getting Paxlovid because but that very question that you asked, it's being reinfected with COVID. As we know, getting reinfected with COVID is pretty common. And yes, they would be, as long as they met eligibility criteria, say immunocompromised, they would also be eligible for receiving another course. So they got, say, COVID in February, and then got COVID again this month. Yes, they could get Paxlovid again.
Okay, great. And can the Paxlovid be repackaged in a blister pack or pouch pack or similar compliance aid?
Yes, you can, as long as you, and that was a question that came up when we were discussing it just last week among our, I'll call ourselves former screeners, because we're no longer screening Paxlovid referrals. Yes, in my mind, you can, as long as it's, say, it's well labeled, which we would know the requirements, and that the patient's informed and they know what to expect.
Next question, does the rapid test need to be witnessed by a healthcare provider, or does a client self-administering, is that sufficient?
So the new criteria is that it's the physician who decides whether the patient-initiated rapid test is acceptable. So the physician feels, yes, I can accept the rapid test from the patient, then that's all that's required. So there's, in the previous model, a patient had to get a witnessed rapid test if they did their own home rapid test.
And why have? Sorry, you're going to add something?
Yeah, I was just going to go back to the previous question about repackaging. So yeah, I enter. There's a lot, and in the community, I'm sure there's lots of different ways of packaging medications. I'm just familiar with our blister packs, and they're already labeled, and that's why we just put a label, or at least told patients what to expect, and we didn't have to do too much modification of the blister packs. But I do appreciate there's lots of different ways of packaging medications. So.
Yeah. So, but I think the question is more focused on no storage instability.
Okay, I understand. Yeah, I don't expect there to be any issues.
Okay. Why have the Liverpool and Ontario drug interaction resources been used instead of a Manitoba drug-drug interaction guideline?
So are you talking about that? So the drug-drug interaction guideline with when we created that one, that was the hard printed copy. We spent many hours on that, but we already knew that Liverpool existed and it was well resourced. The Manitoba particular document was just a list of different drugs, just like a quick referral, but it never actually provided, because we don't have the resource to put down how to manage that, because we always knew that Liverpool had their document, Ontario Science Table also had their document, and that's why, rather than reinvent the wheel, it's to leverage what was done by others. So in our screening, we use the Liverpool. Actually, as I said, I would use all three, just to make sure that I understand what the recommendations were and whether I feel comfortable in doing so.
Okay. If a patient is taking both a DOAC and low-dose aspirin and is at low risk of VTE, what option can or should be used?
That's actually covered in the BC table. And I'm just going to pop out of it and just see if I can cover that. This is probably going to be disorientating for some of you. So they do have here different options. It all depends on the indication and what the low dose is. So, if the patient falls into here, low dose, then they could probably get Paxlovid, no problem. Otherwise, there would be some modifications. Again, there are lots of different options and different scenarios that may relate to a patient. So I can't give a absolute answer for a specific patient unless we knew where they fit in this kind of diagram.
Are the 3 drug interaction resources available at no charge?
Absolutely. So the easiest way I found them was I would type in the Liverpool drug, COVID drug interactions in Google, and then you find the address, and I just dropped that into my browser as a bookmark. And again, same thing with the Ontario Science Table. Just search Ontario Science Table, Paxlovid, pharmacists need to know kind of thing, and you'll find that information. So I'm just going to unshare this particular screen and just go to those particular documents. Can you see this?
Still seeing the science table.
Okay, so let me stop sharing and I'll share. Can you see now?
It says you're starting to share screen, but I'm still seeing black.
Okay. So I'm going to unshare, and I'm not going to pursue anymore because I'm obviously running into technical issues. But yeah, the Ontario Science Table as well as the BC CDC document are available free of charge. And there's, as I said, there's videos on the BC site, but it's specific to their BC pharmacists because they have a different billing procedure as well as requirements for submission of forms, et cetera.
And I think all 3 are linked within the shared health memo,
yes,
as well as we linked them in the member email on Paxlovid that was
yes.
last week. So check your inboxes. If a client missed multiple doses, do we extend the course by adding all of those doses at the end? Is there any max number of missed doses that we would consider adding to the end, or is there kind of a cutoff or threshold?
Oh boy. So you're essentially asking, or who's ever asking, essentially you have a non-compliant patient.
Yeah.
I think once you start missing multiple doses, you basically, the patient has decided to not complete the treatment. And for safety, I would probably suggest they not complete it because there's no guarantee that even moving the doses down the road, it's essentially like saying the patient, for example, decide on their own, well, rather than take twice a day for 5 days, I'm just going to take once a day, once every 2 days, just to try to stretch it out and see if I can make it last longer. It's not going to work, and it may cause harm, may result in the virus developing resistance, and that's not something we would recommend.
Yeah, in this case, it looks like the client missed because they went AWOL. So
yeah,
I'm taking maybe a client who has some other mental health or other factors impacting things.
Yeah, and the same thing applies even for intravenous remdesivir treatment. We've had patients that would go into our infusion center, and then it's a 3-day infusion, but if they miss day 2, we would not pick up again and give another extra dose. Essentially, by missing their day 2 treatment, they've invalidated a treatment agreement, and they would essentially make themselves ineligible for further treatment.
Okay. Here's one. I'm not sure to the extent to which you'll be able to answer this, but the asker notes that in many community pharmacies, the community pharmacist doesn't have a privilege of overlap with a pharmacist to perform detailed clinical analysis. No overlap, many other tasks simultaneously. How long does it typically take to check for the interactions with Paxlovid? And will the physician indicate on the prescription that they've screened for interactions, or will they send basically outsource the work to the community pharmacist for the whole work. Just concerns about burnout. And
I totally understand, and I think I'll just give you I think that in terms of volume, part of the reason is that the centralized model, like we started with one pharmacist a shift during a normal, 8 to 5 kind of system. We had to double the number of pharmacists just because of the volume. And on the average, we would do it takes anywhere from half an hour to an hour to do screening. And I emphasize this many times during my presentation, we had to do a lot of documentation. We had to search the labs. We had to verify their vaccination status. We had to type this information all into the electronic chart. So it took us a long time. So what we would do, at least certainly what I would do, is that I would write down the list of what I thought the active drugs were just on a piece of paper. Call the patient and then before doing this, I would quickly do a scan using Liverpool. And if there's anything that I was concerned about, then I would check another database as well. In order to make sure I cover 2. And then I call the patient. Once you get into the practice, it actually goes fairly quickly. And you can get very efficient at it. It is challenging when you first start off, and I do appreciate the fact that there's pharmacists may not have enough staff. It is time consuming. All I can say is that by having having packs available to over almost 200 pharmacies in Manitoba, that increase the potential that we can get more patients who are eligible to receive Paxlovid. And it may take a little bit of time to do your drug interactions. What patients can get, as long as the patients get their drug, Paxlovid within 5 days. If you get this prescription day 3, you have a little bit of time to do your drug interaction screening. Again, we're trying to get the patients to get their start within 5 days, and there's no clinical difference if they got their start on day 3 versus day 4 versus day 5. So, encourage people just to take your time, not to feel that you're rushed. Just to do your drug interaction screen. Going back to the question about the physician and I would assume the physician has not screened. I would assume they have not screened just because in their schedule, I'm not sure whether they have the time to take an hour, for example, to sit in their office with 10, 15 other patients there to do the screening. So it comes down to us, as it always has been, that we will be the ones who will do the drug interaction screening and identifying options for the physician.
And maybe just, unrelated or kind of leading to offline discussion on that, I'd be interested for those of you who are receiving Paxlovid prescriptions, if you have any feedback you want to provide to me on challenges you're encountering in real world settings, please feel free to email me on those at sib@pharmacistmb.ca. We want to be able to collect any issues that you're encountering or any good and positive feedback as well. We don't want just complaints, but if whatever the good, bad, and the ugly, we'd like to know about it. I think that last one leads into the next question such as when can patients expect improvement of symptoms after treatment, and is there any monitoring plan required?
We actually, the only thing we actually tell them in terms of symptoms, we told them that Paxlovid may not change your symptoms, may or may not change your symptoms, because the result that we were looking at and the way it was studied and the way it was reported was just looking at hospitalizations and death. The study had made no reference whatsoever to symptoms, and I actually do not expect symptoms to change just because the infection's already occurred, and what we're trying to do is shut down more SARS-CoV-2 production from infected cells. So the patient still has that infection going on. We're just trying to prevent more viruses from spreading and making it worse. Okay. So that's what we'd actually tell them, because that's as much as we can tell them.
I've got an anonymous just more of a comment here about what about highlighting Paxlovid studies bias since pharmaceutical companies sponsored this? I hope this bias to be addressed. I'm not sure to what extent you're able to comment on that.
I can't comment on that. That's something I think it's more of something that I don't feel comfortable discussing. I mean, that's a different question. All I can say is I'm comfortable with the clinical trial showing that it significantly prevents patients from being admitted to hospital and from possibly dying from COVID. And we do know from our experience, patients going into hospitals, they tend to be those who are immunocompromised, have risk factors. And, we all know that it's had a significant impact on the healthcare system. So anything we can do to lower that is a plus.
Yeah, and I think as professionals, we have to be cognizant of the fact that, industry does sponsor a lot of the evidence on which we rely. And if you have concerns, then go back to the original study and, evaluate it thoroughly as we were trained upon. But I recognize that can be a challenge given time as well. Is there a template prescription for prescribers, i.e. one that says, send me the kidney function? So i.e. are there kind of like EMR templates or forms to kind of prompt physicians to provide information that might be useful to a community pharmacist?
As far as I know, no. That was a suggestion that was presented to have a prescription template. But my understanding, the feedback was that a lot of physicians or a lot of clinics would often have in their electronic medical records, they would create these templates in their system. So and they have different ways of creating that. So we couldn't have a standard template because they had to be adapted or inputted in. That was my understanding. So as far as I know, no. As it respects to the EGFR, one of the things we recommend was that it's not the pharmacist's responsibility to determine their EGFR; it's a physician's responsibility. So that's why it's incumbent on the physician to assess the patient's renal function, because we don't necessarily have access to their e-chart.
So thank you for clarifying that's kind of the expectation, because I think that's probably something on the mind of many community pharmacists who may or may not have access to lab work. Question in the Q&A. So what is considered day one of infection? Is it the first day of symptoms, as patients don't always test positive on the first or second day, or the first day of testing positive?
That's a great question. So we actually asked that same question at the very beginning. So what it is that when you look at those rapid tests, they consider your first day of symptoms day 0. But as use of Paxlovid, we consider the first day of symptoms day 1. And that's how we interpret the study, because they looked at up to 5 days of symptoms. So they do not use the term day 0. So and again, day 1 for us would be the first day of symptoms.
Any other questions, folks? Okay, if there's no other questions, and I want to first off thank Dr. Gin for his time and expertise here. That was a fantastic presentation. And I, of course, want to thank everyone for attending and for their interest in this important topic. If you have any questions that come up after the fact, you can send them on to me, and I'm sure we can probably get some answers for you. And again, I want to welcome you to send your feedback to us, good, bad, and ugly, on how providing Paxlovid in your communities is going, so we can take that feedback to government. So thank you, folks, and have a great evening.
Thank you for inviting me again. Thank you. Take care, everyone.